Hello and welcome. Today I have Heather Howard, and I'm going to read just a little bit of her amazing resume to you. Heather is a PhD, MPH in human sexuality, a board-certified sexologist and mind-body health facilitator with a clinical concentration in pelvic, sexual, and chronic pain. She founded the Center for Sexual Health and Rehabilitation and developed the ergorotics process to promote comfortable pleasure and create accessible resources for people in all bodies. She's the treasurer of the International Society for Study of Women's Sexual Health, co-founder of the Pelvic and Sexual Health Network of Northern California, faculty in the Sex Therapy Certificate Program at California Institute of Integral Studies, and a provider for the American Association of Sexuality Educators, Counselors, and Therapists. And thank you so much for being here, Heather. So appreciate it. I'm so excited to talk and learn more all about you and your practice. Why don't you start however you want to start?
Thank you for having me, first of all. I know that we met last month, and so I appreciate your interest in this field and in getting the word out to other people who use resources. I know that one of the reasons you asked me here today is to talk about the profession, what it is that we do as sexuality counselors. I am a sexologist by training, and sexology is a discipline that's been around since the 1800s. And a lot of people think, oh, is this some newfangled term you made up? But in fact, it's a discipline that is an interdisciplinary field. So we're looking at human sexuality. It's the scientific study of human sexuality. And colloquially, what we're doing is looking at what people do sexually and also how they feel about what they do. We look at sexuality from a broad lens. In my PhD in human sexuality, I looked at what people did, understanding sexuality biologically, how people feel about sex and themselves as sexual beings, how they tend to define sexuality. So the psychological aspects, the emotional aspects, looking at the relational aspects and the cultural, historical aspects, artistic aspects. So that's the lens from which I come. Often people ask the question, what's the difference between a sexologist and a sex therapist and a sex counselor and a sex coach? Sexology is the discipline from which I come, and I view the world through that lens. It is a broad study of a narrow topic. I'm a specialist in sexuality looking at it from a broad view.
Okay.
Whereas someone who comes from a psychological background, they're looking at a broad number of issues or conditions or challenges from the lens of psychology. So they're looking at more topics from a narrower lens. I'm looking at a narrow topic from a broader lens. If you're looking to work with someone who's a sexologist, there's not a regulation in this field. So we're looking for self-regulation or people who have actual credentials, but the states do not regulate this field. The only field that regulates the term of sex therapy is Florida, in the US at least.
If you have a degree in sexology, you have there's like a college or some.
So that's right. So there are programs, absolutely. So when I say the field's not regulated, what that means is it's the use of the term sexologist is not regulated. Typically, like you can't use the term therapist if you don't have a license in a state. So that's regulated by a state that determines who can use a term. You can't go around saying I'm a therapist if you don't actually have a license as a therapist, at least in the US. And I'm speaking US based right now. Okay. Whereas you can go around saying I'm a sexologist because you think it's a cool term. No one's going to put you in jail for that. However, if you're looking for someone who's a qualified professional, then you'd really need to look more at their qualifications, because the states aren't going to tell you if they can use that term. Just like someone can't say I'm a medical doctor if they're not actually regulated, licensed to practice medicine in their state. But here, there's not a license, there's not a state board that oversees our field. So
it's like a coach. It's the same thing.
It's like a coach, exactly. While I'm a sexologist as a function, what I do as a sexologists have lots of functions. So some of us are researchers, some of us are educators, some of us are clinical sexologists, or we apply what we know from the research in a clinical setting. Some of us are art evaluators. Some of us specialize in forensics and sex crimes. So we have lots of different areas that we might specialize in. As a function, I'm a sex counselor, or otherwise known as a clinical sexologist, but I apply what I know from the field in a clinical setting. And also, so functionally, I'm a sexuality counselor. I offer counseling to people around sexuality issues. I'm not a general counselor, I'm a sexuality counselor. So that's where I'm a specialist.
And I can, let me start by dispelling the myth to the audience that clinical sexologists or sex counselors do not have sex with their clients, correct? Because there are people that do.
There are lots of people who may use the term and not be qualified and I'm a sexologist, and basically they're sleeping with people. That is not actually what someone who's a qualified sexologist does. And I'll caveat that. Someone who does sex counseling, like in my field, what I do, I use an educational lens or approach modality when I'm working with clients. I'm going to be giving them information, relevant education to answer their questions. I'm going to be giving them a safe space to consider their feelings and, to what it is that they want, and to really be able to explore identity or whatever it is that is important to them. And I'm going to be giving them specific suggestions, so that I'm really a skills trainer. I am an educator at the heart of it. That is what a sex counselor does. We provide education and skills training. In my work, everyone stays clothed. And even when right now I'm doing everything online, and I work with people all over the world online. And because I'm an educator and I'm not a therapist, I can work with people anywhere. I'm giving them information and skills training. So I work online, and in my clinical practice, when I did see people also in person, I never had people undressed. I never touched my clients in a sexual way. And even when I was working with couples or thruples, they would not be touching each other sexually in my clinic. So I might be giving them some experiential exercises to try in clinic to learn a skill. But if there was any sexual component, they would be doing that at home as a home exercise, and then coming back in and processing what they learned in their homework.
Okay, so let me stop you for a second.
Yes, yes.
I love that. I learned that in coaching, and I think that's a great way to talk about it. So why would someone come to you versus, that's question one. Question two is you versus a sex therapist, and then we'll go later into the coach or whatever you want to talk to people.
So I want to just define what a sex therapist is too, before telling you why someone would go to someone differently. So a sex therapist, again, in most states, the only term that's regulated is therapy. So lots of people can call themselves sex therapists, whether or not they have any specific training in sexuality. Yes. So if you're looking for someone who has specific training in sexuality, who is also a therapist, you'd be looking for a place like ASECT, the American Association of Sexuality Educators, Counselors, and Therapists. Everyone listed on their website, they would notify if they're a sex therapist, if they're a sex counselor, or if they're a sex educator. And those people would have a certain amount of training. So there are standards for the amount of training they have, the amount of supervision they've had, and mentoring, and in order to become certified. So that's one of the organizations that regulates this field. There are other organizations as well, the American College of Sexologists, the American Board of Sexologists, which also have standards, but ASECT is perhaps the best known in this area. So there are lots of therapists who've gone on to get additional training in human sexuality. They may work through the lens of sexology, or they may work more as therapists who also have some extra skills in human sexuality. They may have a very broad practice and also work with sexual issues. Whereas for me, I'm only a specialist.
Interesting, because I'm in the Sexual Health Alliance program to certify as an educator, and there are a lot of licensed therapists there that are getting their specialty. And what's really interesting is that the bulk of the people, at least that I've seen in some of the classes, most of it is just self-study, are in alternate lifestyles or practice different types of sexual practices. So there's actually one of the educators who is also a sex worker in addition to being a therapist. And it's interesting that I don't know if that's, I don't assume every therapist that is a qualified licensed sex therapist is also practicing those practices, but I just thought maybe it draws those people more.
So many do. People come to this field for many reasons. I came to this field because I have a pelvic pain condition. So I came to the field through my own experience too. That became my specialty because it's an area I had an interest in studying. So I studied pelvic pain and sexuality for my dissertation, and have spent a lot of years understanding the many ways in which sexual pain presents and pelvic pain presents. and how to support people with that. Yes, we all come from different backgrounds. Whatever draws us into the field may be that we may feel that we don't have the kind of support that we need for our practices or for our health. And there's a real need for it. And that may be a calling that we can make a difference for other people. I know that was my calling, where I was looking for information and to understand better what tools were available to me with a pain condition which debilitated me and had a huge impact on my sexuality. And sexuality made my pain condition worse. And when I asked my providers for information, there just wasn't much. They started asking me to talk to their patients because I could talk about sex. So as a patient advocate, they just started asking me to talk to their patients. And I said, I think I'm really being asked to do this now. So I'm going to go back to school and get qualified. Oh. But we all find our ways into the field because of our own personal interests and motivations. What we know is, sadly, just addressing pain doesn't necessarily get people back to sexuality. We find a lot of people with pelvic pain may go through treatment, but once they're out of the habit of connecting sexually, it may be very hard to re-engage. They may have withdrawn from any kind of touch because of fear of pain. And so being able to to expand their comfort zone again. And some people have never had comfort with sex, but many people have perhaps had pleasure or comfort, and then something has changed. And then they've withdrawn, or they become traumatized by the experience. And so it's really important to be able to work with a multidisciplinary team of medical providers to help with the pain, but also someone to help not only the individual, but also the partner, the couple, to adjust, because everyone's been affected by a breakdown of connection, or a partner who may feel like their body is causing pain, or one of the things that's provoking pain may leave the partner feeling really afraid to re-engage too, or feeling rejected. And someone like me, a sex counselor, would be able to work with not only an individual, but also a couple, and help figure out how to expand that comfort zone again, how to start engaging in activities methodically, to expand those activities by doing an experiment at a time to see what feels comfortable, what does feel pleasurable, and rather than just focusing on what's painful. There's so much of the medical model is focusing on pain. We're not really validating or focusing on pleasure. When I meet with people, the first thing I'm going to ask them, besides what brings you here and what's your vision at graduation, is what's working for you now. Because what I want to know is, where are we starting from? Where's your foundation, and how do we build from your strengths rather than just focus on the challenges or weaknesses? I think it's crucial to be able to find providers who can help. And sadly, there aren't many people, even mental health providers, who focus on sexual pain or pelvic pain, who understand the fear-based response and how important it is to be able to come up with some specific strategies that people can try to reduce their fear and build confidence again, and also build reconnection with their bodies. One of the things that happens when people have chronic health conditions is they often feel that their bodies have betrayed them, and they may be pretty angry with their bodies, or feel really, really separate, and also shut down and not feel very much. That's another common thing, because feeling may be risky. It could be painful. So helping people to re-engage or to rebuild that connection with their own bodies and their own confidence and trust in their own bodies is important.
So how do you work with patients or clients rather differently than a pelvic floor physical therapist does? Because I know one of the things they do is they help you physically retrain your body, not to clamp up, for a woman, at least, when you're being penetrated again.
Yep. I think pelvic health physical therapy is crucial. It gives people a chance to get an embodied experience of building their own strength, their own comfort. Absolutely. And I would say pelvic health physical therapists saved me in my chronic health condition, for sure. So typically what I'll do is I will want to collaborate with the whole medical team and understand what the physical therapist is noting, or if the client's really aware of their bodies already, that's helpful. But understanding their pain mapping, what feels comfortable, what feels painful, and to know how we might design sexual activities or exercises that don't provoke the pain, but that actually they can start discovering what is pleasurable. So I'll normally try and talk with a physical therapist or get notes so that I understand what they're working on already. I'll want to understand what the doctor is seeing and understand the prognosis and what they think the causes of the pain, so that I have a sense of how to find a pathway to pleasure with that client. So what I do that's different is I'm not touching my clients. I'm not examining them. I'll be relying on the medical providers for that information and the client as well for their experience during those exams and just their own life experience, because I'm working collaboratively with the client most of all. My job is not to be the expert forever. It's to help them build their own expertise in their own bodies and their own sexuality and their own lives. So I will normally then get a sense of what is working so far, what the challenges are, what someone's vision is for graduation, like how they would like to see their lives when they graduate. So I'm not just focusing on pain, I'm actually focusing on quality of life and pleasure. And then helping people to build, often on day one, some exercises where they can begin noticing what brings pleasure or enjoyment to their lives, to their bodies, and ways that people can engage. So I might be doing guided visualizations with people. I might be giving them extra home play to do sensual savoring, to notice what they feel in all of their senses. Sometimes we get so focused on what pleasure can be and we think it's all genital, but we forget that pleasures can be experienced with all of our senses in the entire body. Really trying to help people feel more competent and functional from day one so that they can build on that. So I'll be giving people activities and exercises and information. When someone sees me as a couple, even if I may see some of the partners individually throughout the process. Normally it's, if they're ready to bring a partner in earlier in the process, it's helpful because there may be a lot of disconnection between the partners and a lot of misunderstanding and difficulty communicating. So I'm often going to be helping people with sexual communication. Just talking directly about sexuality is important. Sometimes just working with a specialist, even if someone has a therapist who's really comfortable talking about sex, which is great because a lot are, working with someone who's a specialist who's there for that purpose keeps people focused on this topic. And some people can want to avoid it because it's so uncomfortable, but they may come to a specialist because they know that it's something they really want to be held to focus on. They know that it's important.
I imagine by the time someone gets to you, they're ready to talk, but they've been so afraid to actually even bring it up to people. And so providing a safe space. And I see this like on a much more higher level with the people that I try to talk about menopause, and people are, oh my God, I can't talk about it. Like someone might hear me, like, let alone sexual issues, what it takes people to be able to communicate that they even have them. So providing what you do is, or allowing that space and saying, you can say anything to me. I think it also helps people be able to talk about it. Because for me, it's easy. Like it wasn't always easy, and there's still conversations that get a little uncomfortable. But if it's even uncomfortable occasionally for me, I can't imagine what most people are feeling when they really need to face a serious issue.
Right. And then, of course, we have the challenge where it may be comfortable to talk to a provider, but it may be hard to talk to a partner.
Yeah.
It may feel really vulnerable. Allowing people to develop a shared language around sexuality where they can figure out, they can define what the terms mean that they're using. Sometimes there's so much misunderstanding because their terminology isn't defined. So being able to break down, what do you mean when you say sex? That's a big one, right? Some people assume that we know what that means, or what does it mean when you say maybe? So really being able to break down that and talk about it where there's less of the immediate emotion or risk, it can be helpful. But so often what I'm doing is I'm facilitating conversation for people. I'm helping them, as you say, just have a safe space where talking about sex is normal, and where I talk about this all day. And so it feels okay. I may not offend you then or make you uncomfortable. You do this all day. So that can be really important for people. And so they can begin to explore their own feelings without worrying about being judged. And that's a crucial component for someone who does the work that I do, is to be able to hold a space where I'm not judging my clients. And I'm really doing my own work to ensure that any of my own values are not being brought into the session. You know, the values I will say up front that are important are that I do promote consensual sexual behavior. And so if there's not consent, I will want to talk to my clients about that. But other than that, and risk aware activities as well, as people may not be aware of the risks that they're taking. And I'm not a fear monger in any way. If people are practicing activities which may in fact put them at risk, it's my job to let them know that too, so that they can make informed decisions. But ultimately the decisions are theirs.
And so it sounds like you do both the sort of the mental health piece of it, and it's all mental health, I guess. It's all, the brain is the biggest sex organ, but helping them not just be able to deal with whatever the mental blocks are, but physically how to get through them.
Right.
Like an action plan.
An action plan. So often what people are looking for is the how-to. And that's what providers, like clinicians like me do, is we provide the how-to. So it's step-by-step, what to do, how to talk about it. You have a pain condition and you're dating again. How and when do you talk to a partner about this? So that's the kind of conversation I'll have with clients. How to, or how can you stimulate? What are some alternative ways to stimulate yourself if this is painful? Or what positions will be perhaps helpful for you? And I know you mentioned the ergorotics process that I developed. Lots of people need resources for how to adjust with specific pain conditions. Basic how to adjust. And I realize I can't see everyone in clinic. Lots of people need resources and they can't all come and see me. And so I put together some video courses for people, which are focused on some of the most common health conditions that are based on the ergorotics adjustment process. Ergorotics is erotic ergonomics. It's my term for erotic ergonomics. And it's really adjusting the activity and the environment for the people and the comfort and the pleasure of the people involved. I put together a video for people with back pain and back surgery, spine problems.
Ooh, I'm going to get that one.
So often some people are motivated to have surgery because they want to have a better quality of life, and sex is a part of that. But then their physicians may not be able to talk to them about what the adjustment process looks like, or how to thrive with their pain condition or after surgery. So I put that video together, and certainly it builds upon what we know from the medical side and the kinds of questions you can also ask your physical therapists and doctors in order to have more satisfying sexual experiences and to be able to address repetitive stress that might happen from repetitive actions or motions. I also made one for people with hip and knee pain or surgery, because these are, again, the most common challenges that people have with osteoarthritis. And they're going to have pain in their knees or in their hips, or they're going to have surgery. What I did is I looked at what the common medical guidelines are and said, certainly ask your doctors about this, but here are the kinds of things you might be able to do to adjust. And I think it's important that people understand an approach to adjustment. And then I also did a video on pelvic and sexual pain. So it's for people who have pelvic and sexual pain to know what kinds of, so there are scenarios, what to do if I tend to prefer a facing away position, but I have pelvic pain. How do I make adjustments so that I can have more control over the movement and the position, which is very important for people. If you have pain, fear of pain can make your pain worse. And also it can cause tension, which can make your pain worse. So especially with pelvic pain, tension in the pelvis can certainly cause more pain or cramping. So trying to find ways to have more control over the movement strategy, having better pelvic alignment to not rub or cause friction in the areas that tend to hurt the most, being able to manage the depth of penetration. So all of these things may be important. Those are focused on penetrative sex, mostly because those are some of the most challenging things for people with pelvic pain. But I also want to say that for people with pelvic pain, genital stimulation may not be what they want to do ever or anymore. And penetrative sex also, even if they want genital stimulation, they may not prefer penetrative sex. Lots of people without pain don't prefer that either. These are the biggest adjustments or challenges. So I did focus on penetration mostly in those videos for people to understand the approach to the body mechanics. But really, it's important to understand so that people can then become experts in their own process and know how to work with their providers to get what they need.
And this is really great. And I'm definitely going to put links to all this in the show notes, because certainly as we age, I did some earlier episodes on back pain. And that's one of my issues is I plan my physical therapy when I'm going to be active. It's actually active. I know I need the physical therapy the next couple of days because my back, if you get in the moment, otherwise you're just so busy being cautious of, oh, wait, don't turn me that way. I can't lie that way. It hurts.
Yes. Yes. I understand completely. And as someone who also has chronic health conditions and mobility limitations, I absolutely understand how important that is. Hopefully the videos will help. I also do ergorotics assessments with people, which can be a one-off or a couple session where we're really focused on the mechanics of sex. People coming in and I really want to work with all the partners involved, but understanding what it is that feels good to all partners, what limitations they may have, what's the room in which they're sexual, and looking at it's been great since I've been working over video because I can actually see the environments in which people are sexual, and we can do some dress rehearsals of getting into and out of positions even, and I can see it in their environment and say, oh, maybe you should put that pillow there. Or in one case I was working with a couple, this is before everything was online, but they worked with me in person, but one time they were home and they came in from online. And I was able to actually see the room in which they were sexual, and they were having sex on a futon, which had a bit of a lean, and they were having a challenge. And I said, what if you just like reversed and you went backwards, and suddenly it resolved everything for them.
Wow.
But I wouldn't have known it without seeing their environment. Sometimes it's that was a happy accident. Now I really get a chance if I can show, I put together the ergorotics process along with a library of ergonomic sexual positions for providers as well to use in their practice, like I would use with my clients. I can bring up the images and the moving videos to show people while we're in clinic demonstrations, and then I can send them the pictures so they remember what to try, and then they can actually do the dress rehearsals, or if they need me to visualize with them and help them figure out what that looks like for them, we can do that in a clinical session. And I definitely recommend experimenting and dress rehearsals, because waiting until you're already excited to try something new and like, how do I get into this newfangled position, can ruin the mood. But if people can try in advance, that can be helpful too.
And that goes also to this whole idea of scheduling sex. It's like that whole idea that you really need to plan at some point, like you need to plan it on every level. It doesn't take away the fun. In fact, it probably makes it more fun.
No, it's so funny because a lot of people think sex happens spontaneously. But in fact, if you think about those early days of dating, usually you're spending hours getting ready for a date, getting in that mindset, doing whatever you need to do to feel confident in your body for the possibility that sex might happen, right? So there's so much preparation that probably was going into, your dating life all the time for that potential spontaneity. But people need to have their transition rituals and processes many times. Some people don't, great for them. But for the most of us, we need some transition time to get our minds more in the mood, and also perhaps to feel like our bodies are relaxed, or to do treatments, or as you say, plan to know you're going to have physical therapy. So if sex is going to cause you any discomfort or pain, what treatments you have following. It's a great idea.
And now how would you advise like a single client that is like about to, because a lot of my audience is divorced and now we're like back out there getting sexual again after a long time, and either ouch, it hurts, or it's dry, or whatever, or I have pain. And how do I tell him or her that I feel like guys are really okay with, I got to go take my Viagra if we're going to have sex tonight. I feel like that seems to be an understanding, which fortunately for me so far, none of my partners have needed Viagra. They've had other issues, but that hasn't been one
that you know of. That I know of. Right.
True.
So not everyone is comfortable. Not everyone with penises is comfortable letting people know they need to take Viagra. And actually, Viagra may work for some people with vulvas too. However,
I've heard that.
Yeah. Yep. But yeah. So what would I advise to my single? So first of all, the more about your own body and your own pleasure, the better, because people are going to be relying on you to teach them about your own body. They may be wanting to explore, but the more you can help them or participate in the exploration, the better. People aren't just supposed to know what to do. Every person is different. So the more, the better. And also, if you're having pain or discomfort, get a medical evaluation. Find someone who's qualified in sexual medicine. Certainly, as you're focusing on menopause, the menopausal transition is a prime time for people to start having some genitourinary symptoms, which are a function of changing hormones and hormone depletion. And if you're having those changes and dryness, going to see your physician to see if there's anything that can help, if hormones can help. Certainly, vaginal moisturizers can be helpful. and also lubricants for sexual comfort. That is important. And people may be worried, what if I need lubricant? What if my partner thinks lubricant's going to make your partner's experience better 95% of the time? There are some people who find that they don't have as much sensation when they use lubricant, but that's not as, I don't hear that often. It could be someone whose partner has some sexual challenges too. And so they're having a harder time feeling, or they may have erectile difficulty. And so they may be anxious. They may have their own challenges. So this is the thing. When we're going out in the world, a sexual relationship is really something that's developed between the parties or amongst the parties. And so one person is not responsible for any challenges in sex or all the pleasure in sex. And sexual relationship is really that. It's a relationship. And the sex you end up with is a function of all the people involved. And someone can have a pain condition or a challenge that doesn't even register as a blip in one relationship because both people have a lot of mental flexibility. And then they could be with a partner who has a very narrow view of sex or what they can do or what they like. And any challenge might end up being a real problem. Everything is about the partnering. What I find is the mental flexibility is way more important than having all the physical flexibility of youth. The more mentally flexible people are, the more they're going to be able to find solutions. And I love a good challenge. I love when people come to me for an assessment and they're like, okay, I've had hip surgery and knee surgery. My partner has a back injury and has erectile difficulty. What do we do? And I love those experiments because we're all brainstorming together. I'll make recommendations, but we'll talk about how the recommendations feel for the parties. They'll do some experiments and come back and process how they work, and then we'll tweak those along the way. But I love that. I love the challenges. And usually people come with things that might stump me too, but we work through it together.
And I think even though it can be a challenge, I do think that people, at least that are post-divorce or in their 50s and 60s that I've come across, they are more open to these conversations because you're not the first person that's having it with them. They've seen it before. And I know when I'm older, things are if you're going to date somebody my age, you're going to have arthritis or whatever it is, erectile dysfunction or
Absolutely.
Something is going to be part of the mix.
But I think your question about what an individual can do, getting out in the dating world can feel scary, especially if it's been a long time since someone's dated. If someone was recently divorced and hasn't dated in 20, 30, 40 years. And I think practicing going out with people and not expecting each thing to work out, but really just getting back out there to meet people is important without expectation. Experimenting is one of the most important things we can do, and being willing to learn from experiments rather than have expectations of success, whatever that may be. But getting out there and meeting people, practicing talking to friends about sexuality can also improve that discussion. Working with a sex counselor to talk. For some clients, if they've had major changes to their bodies or an injury, they may be worried about, I don't know how my body's going to be with another person. I don't know if I want to discover it for the first time in an organic relationship. I've had some clients work with surrogate partners in those cases where they've learned about their bodies in a safer playground with someone who is able to explore with them. And surrogate partnership's a whole different topic, I'm sure, for a podcast, but it's a way that some people, if they really have a challenge, and they feel that they're too uncomfortable putting themselves out there without knowing how their bodies will be, but then they're not going to know how their bodies are going to be until they're with someone. That's one of those times when I might say surrogate partner process may be helpful.
Now, since we alluded to that being actual physical therapy.
Yeah, and you brought up earlier, and I did want to come back to that. So I do not touch in my practice as a sex counselor. That's not what I do. However, there are disciplines or there are professions of people who have training in somatic sexuality. So there are somatic sexuality educators who may work through touch directly. There's actually a field called sexological bodywork, and there's a certification in sexological bodywork. And people have training to work with people in states of sexual response. So a physical therapist is not going to be working with someone who's intentionally aroused in any way, but a sexological body worker is actually trained to help people learn about their own function in a safe space. What makes them different from any other kind of sex work is that there's training, there is mentorship, there is a code of ethics in the work. And with sexological body workers, it's a one direction touch. So they touch their clients. The clients do not touch or pleasure them back. There's a very clear code of ethics. People know what to expect. And so I have lots of people who have had difficulty with orgasm. I can help a lot of people, giving them suggestions, working through any roadblocks. And yet for some people, they may need someone to be able to do masturbation coaching, to observe what they're doing and help them feel, hey, you're doing okay. Keep breathing. This is the time to take a breath now. Your body is really tense. See if you can move in this way or relax your body. So it's a wonderful profession for people who maybe have had trauma in the past and need to be able to learn about their bodies in safety. People who've had trauma, sometimes their nervous systems may confuse arousal with nervous system activation. And so being able to have someone try and help someone feel safe and be present, that's something I'm not going to be able to do with someone in the moment. So this is where a sexological body worker could be really helpful. They can touch a client, but they can also observe and teach. So that is one form of work where people can touch.
How is that different from the surrogate?
And a surrogate partner the surrogate partner.
That sounds like I could just hear the audience saying, yeah, it's like a hooker or gigolo, like that.
Yep. So surrogate partner therapy has been around since Masters and Johnson. They developed this program because they didn't want to work with individuals in their practice, because they recognize that sexuality it lives differently in every relationship, right? The environment in which it lives will affect the experience. So they've realized that if they actually had people who could interact with their clients, they could help individuals. And so it is a triadic relationship, surrogate partner therapy. So someone will have either a sex counselor, they'll have some sort of clinician, a sex counselor, a certified counselor, or they'll work with a therapist. And so there will be a triadic relationship with a surrogate partner, the client, and the therapist or clinician. And everything that is done in clinic is done with with an intention to help someone meet their goals or work through a challenge. So it's not about someone just giving you pleasure or going and fishing for you and giving you a fish. It's actually teaching you how to approach fishing. You would try an experience, and every experience is designed with an intention of learning, and then with a surrogate partner, and then you come back to work with the clinician and generalize the individual experience you just had and understand how that relates on a bigger picture. No one would move to another activity until there's a likelihood that's going to be reparative rather than traumatizing. But it's a very controlled approach. And this isn't someone you just go and you meet and you have sex with. In fact, surrogate partner therapy is about partnering. It's not about sex. It's about the partnering aspects. So certainly you can experience touch, and it could be sexual touch and erotic touch, but it's really about what happens to you in the partnering dynamic in those experiences that we're concerned with, and that we're going to help clients learn how to work with.
Interesting. And how do people not get emotionally attached to those surrogates?
Yeah, they often do. And that's an important part of the work. These are authentic relationships. So no one's acting. Everything that a client does, a surrogate partner will do too. They're building an authentic relationship. They're not meeting organically. They're meeting through the clinical relationship. And yet they're building their connection through experiences. It helps people learn how to build intimacy. And so they are building, a lot of people will fall in love with their surrogate partner and vice versa. And it's a wonderful thing that happens, because it teaches people that they can have those feelings, and they get a chance to go through an entire arc of relationship, from meeting someone, developing comfort, and slowing down processes that are usually happening pretty quickly, and processing what comes up for them at every stage of that connection. And they go through the entire arc until they also have a respectful ending. So we know from the very beginning that this relationship will have an ending, and we plan for it. We process the feelings that come up, because let's face it, most relationships do end. So most relationships will end. Every relationship will end ultimately. It's important for people to be able to practice getting into relationships and also getting out of relationships. And often people end the surrogate partner relationship before they've reached their ultimate goal of the work, because they start dating organically during the process. That's an optimal situation for people, where they get to the point where they feel confident enough they can go out and continue their learning organically, rather than wait until they've met every single goal to go out and put themselves out there. But as they build more confidence through the process, often they're meeting organically and they're continuing their experimenting.
Interesting.
Yeah.
Okay, so surrogate, somatic, and any other ones that are supposed to touch you, so to speak.
Those are the biggest, I think the bigger categories. Surrogate partner therapy is, again, is bidirectional and it's about partnering. Sexological body workers are really helping you get into a trance state and understand your own, often the mental process that you get into to be with yourself. It's not a relational thing. They're there to facilitate your learning more about yourself and the experience. Certainly the relational work with a surrogate partner teaches people about how they show up in relationship, but the relating aspect is the most crucial part. Whereas in sexological body work, it is really someone else facilitating one's relationship with themselves. And so those are the main categories. There may be other people who practice similarly, but they may not be regulated or have a code of ethics. And when I'm going to refer to someone, I'm going to refer to someone where I know what their training is, I know their code of ethics. And there are a couple training organizations for surrogate partners, and one is the International Professional Surrogates Association, IPSA, and another one is the Surrogate Partner Collective. And so they train people, and there's a whole apprenticeship program, so people have mentors for their cases before they become certified as surrogate partners, but they go through the process. They're always working with a clinician every time. So if anyone calls themselves a surrogate partner and yet they say, sure, I can meet with you, they're not doing surrogate partner therapy. They're doing something else, but it's a very defined program and approach. Yeah, so those are the ones I would recommend because I know what the approach is. I know what people are going to expect. And that standardization gives, not that every single person works exactly the same way, but that amount of standardization gives me a sense of how to work with someone and to know that clients are going to be working with someone who has ethics. There's some people out there who might be doing clinical work with people and doing touch. That can be controversial, doing both with the client. Whereas I think if someone's going to be touching the client, that I think it's good. There's so much transference that happens in a relationship and counter transference, and that's important. But the reason a surrogate partner is going to work with the clinician too is to really help people understand how that is playing out in the relationship and how it's helping. What do we learn from that? But we need someone outside of it who's not getting in the weeds in the relationship, who can actually see outside of it and support. Like my job when I'm a clinician with those cases is to support the client and the surrogate partner in the relationship because they're both in the relationship.
Oh, interesting. Wow. Yeah. I did not know that was a thing.
Yeah.
Great.
So yes, so when you mentioned people have these ideas about what different people like me do, I do not touch my clients as a sex counselor, and that wouldn't work with my code of ethics. That as a certified sex counselor through ASECT, that I'm not able to touch my clients. Whereas for someone who's a certified sexological body worker, they can work through touch and they can have nudity and they can have arousal in their work. And they are trained to work with that specifically and to hold that space safely too.
So if someone calls themselves a sex and intimacy coach, it's just like anybody calling themselves any kind of coach, regardless of a certification. It's not really a thing.
But there are coaching certifications too. And I believe ASECT may certify sex coaches as well as sex counselors, depending on their training. The key is that you want to know about their training. You want to know about the modalities they use. You want to, again, because it's not regulated, a lot of people who are sex counselors may also call themselves coaches. Because the model that we use is, it's solution focused, and we're giving people practical things to do. That is a coaching approach. I use education and skills training, but that's coaching. I don't call myself a sex coach. I'm not trained as a coach. People who call themselves sex coaches, I think, also go through a coaching program and learn how to apply it in the sexuality field. And there are programs out there, and there are some in other countries as well. I know sex counseling in the UK, I think they call it psychosexual therapy. So there are different, again, depending on where people are based, they may have different names, but the important thing is really because we all have different names for what we do, to ask more about the training, ask about the code of ethics, ask about any kind of regulation or oversight, because that's important for people to understand who they're working with. There are a lot of sex workers who do great work and really help people. And there are lots of sex workers who don't. So I think, and just because someone's certified in something doesn't mean they're going to be great at what they do either. But those conversations help you really understand someone's background. If someone's able to talk about how they work and what they do, that can give you a little bit more comfort about what you're getting yourself into. All clients should be able to be informed going into the experience, knowing if they're going to be touched, how they're going to be treated, what the model is, and what the modalities are. Asking those questions can be helpful for anyone. That's not to say there aren't people who call themselves other things who aren't really great. I just don't know about all of the labels, and there are new ones all the time. So I think it's really understanding, how did you get your training, and what kind of supervision have you had? And is there any kind of code of ethics in your work, and what can I expect when I work with you?
And then feeling comfortable. I think that's the hardest thing is someone has a therapist and they don't like them. They think all therapists suck, or they're afraid to end the relationship. Just like anything, you just keep trying until you find the person that you click best with. And at different times and in different relationships, different people will be more appropriate for you. That's certainly what I found, that I ended up changing to someone who did EMDR because I wanted to do EMDR.
That's right. We all have different toolboxes. And even though I'm a specialist, I have my toolbox. If someone comes to me and I think, hey, I think that's not an area I specialize in. There are people who are really specialists. I'm going to find someone who does that all the time. I work with a lot of clients who practice conscious non-monogamy, but that is not my area of expertise. And so if someone is really wanting to learn, how do I navigate this? How do I find groups? I'm going to refer them to someone who really does that. So just because I'm a sex counselor doesn't mean I do everything well or I know everything. But that's the other thing. I think in order to figure out if someone's going to be good at what they do, I think knowing what you're good at and what you're not good at, and being comfortable saying, hey, this is the limit of my scope, is super important. Because I know the things that I'm good at, and I know the things that I need to learn more about. And I think it's not ethical for me to keep someone in my clinic if they're not improving, or if I feel that really there's someone who's got better skills or different skills, and I'm going to refer them out. I like making suggestions, but but it's really up to the client to tell me what will work for them. I can only explain the theory behind it or why I'm suggesting something, but I can't say it's the right thing. And if they're really not responding to the tools that I have, then maybe I don't have the right tools for them, but that doesn't mean that they're failures. Right. It may mean that we just need to try to find them someone else who's a better fit at that time. Or I may have taken them as far as I can take them, and it's time for them to find someone different. You mentioned something which I also want to come back to, which is about that relationship, that clinical relationship. We know through studies that the most important component to someone making progress with a provider is that clinical bond. And so if someone doesn't feel safe with someone or isn't building that bond, then there may be a true limit to how far they can go. Whereas shopping around for someone with whom they feel comfortable may be crucial. Or if they've met a lot of people and they don't feel comfortable with anyone, which does happen, also maybe working on that with the provider. Hey, I'm not feeling comfortable with you, and this seems to be a trend. I don't feel comfortable with therapists. Maybe I need to work on figuring out, is that something I'm bringing in? Or is that really just I'm not finding the right people? But that could be an important focus of that clinical work. Right? Why is it that I'm not able to why am I not building bonds with my providers? Right. And is there anything I'm bringing into it? That doesn't mean blame the client, but it means it's worth exploring too, to see if there's something that a client could do to make the experience feel safer for themselves.
Anything else you want to add that we didn't cover in the different areas of sexology?
I think you asked some really good questions. So I hope that I've clarified that we all work a bit differently. And while we might have similar titles, it's important to really ask people a little bit more about what they do. The other thing, I guess what I would add is, people often wonder, at what point should I start working with someone? And people are motivated to start working with people for a variety of reasons. But I would say the earlier in a challenge, the better. And the reason is that the longer something has gone on, let's say someone because sex is biopsychosocial, if someone has had a pain condition and they've begun to organize their entire lives around the pain condition, when the pain's gone, it may be harder to change their lives again. So the earlier someone can address something, the fewer other layers there are to have to tease out. And if you're in a relationship, often people will just avoid for a long time. And listen, if people feel avoidant and they can't face something, I don't judge them at all. But thinking it's just going to go away by avoiding often leads people to just the relationships going away.
Right.
Or the partners being so frustrated that by the time they reach out for help, it's a final, it's just, can you save us? But we're basically done. Whereas if we can address things earlier and the partner's feeling seen or understood, or someone doesn't feel like they need to be so avoidant, because there are things that they can engage in some ways safely, either in conversation or in any kind of activity that feels connective, there are fewer layers to then have to address later. So I guess that's what I would say is people do things when they're ready, and they do things that serve them. And if they're not ready, I don't judge that at all. But knowing that there are people out there to help, I think it's worth even just a conversation, an initial conversation, or one session, just to see, hey, are there some ways you can help me? And even just to talk about the resistances themselves. I have a lot of people come to me individually who are in partnerships. They don't want to come with their partners because they're scared. They don't know me, and they're scared they're going to come to me and I'm going to say, okay, you came to me. Now that means you have to start having sex. And what I'm going to do in reality is understand, do you even want to be sexual? What is it that you want? How do we help you get what you want? And if you don't want to be sexual, let's first of all have you normalize that for yourself. And I will embrace you in that. And now let's figure out what that means for this relationship. Or if you recognize you don't want to have sex, but you're willing to because of a partnership, what does that mean? And how do you negotiate that? But I have no agenda for my clients. I don't, just because someone comes to a sexologist doesn't mean that the expectation is to have sex. In fact, a lot of people come and they learn when they come to a sexologist that maybe I'm asexual and I just needed someone to tell me that's okay or that's normal. And of course, asexuality is a spectrum. That's again, maybe another podcast you want to do with me or someone. But oftentimes what people need is just to process their feelings and their resistances and have someone be able to support them in whatever they do feel and normalize that. And by exploring that, may make it easier to figure out then where to go. But sometimes just one conversation to recognize these are my resistances. This is why I don't want to work through them, but at least I feel like it's okay to be where I am. Some couples come to me just to have me tell them it's okay to not be sexual because they don't really want it, but they think it's weird. And I'm like, actually, lots of people don't want to, be sexual at this. That's just not what they want in their lives. As long as you're both okay with it, that's what matters. But so I think it's sometimes just going to someone who will not judge you, who will allow you the space to process what you do feel can be helpful. And this is where I think it's important to talk to providers about the training. Not everyone who calls themselves a sex therapist has training in attitude awareness and can hold a non-judgmental space. So I think it's understanding, like, what did your training consist of? What are your values? What values or goals do you have for me?
Yeah. And one of the things I also learned in my training is that it is important to go to someone who understands your lifestyle. If you are somebody who practices open relationships, if I am somebody that believes you're supposed to be in a monogamous relationship for the rest of your life, I'm going to judge you, or I'm going to spend half the time trying to figure out what that means before I can actually help you. So to try to find people that really understand what you're struggling with in your paradigm of relationship, whatever that may be.
And one of the biggest red flags in my field is the word should. If I ever hear a provider saying should, that is okay, they're not coming from a sexological lens. From my perspective as a scientist, and I'm a clinician first, an educator second, and a researcher third. I've done all of them, but I'm coming from a scientific perspective, and that is my lens. If people want some sort of moral help, they should go to religious authority, right? But my job is to come at this with a scientific approach and help them meet whatever goals they have within their value system. But as soon as I hear shoulds, that makes me wonder about the lens. If someone says no one should be monogamous or no one should be non-monogamous, right there, I'm going to say, hold on a second. That's not for us as scientists to say. That's not our role. That may be the role of clergy if we want to, and we know their belief system, right? We choose a religious, authority based on their belief system, and we know what that is. It's up to people should know our belief systems too. And that's not my place to say that for someone. But so that should is a red flag in a provider. And often people feel shamed by providers because providers think they're doing the best they can, but they don't know. And, that's a concerning thing when we feel that way. We can tell our providers, hey, that felt really shaming, or, that felt like that was very judgmental and I'm not comfortable with that. But often people just vote with their feet and they walk away. But sadly, those providers may not know that they're bringing a lot of their own value systems to their clients. Sometimes we don't have to say we think something's wrong. People can feel it in our body language. Like we express in so many different languages. If someone doesn't feel supported by a provider, they're not going to ask for the help that they need. So I do think it's important that people recognize they should be shopping for providers that can help them. I get a lot of calls from people looking for a provider for their clients. I will tell them if I'm the person who can help or not, or try to help them find someone who's non-judgmental. ASECT is you may find people who are fairly non-judgmental, but again, you have to use your gut. And if it doesn't feel right, trust your gut.
Yeah, absolutely. Absolutely. That being said, how do people find you?
heatherhoward.com was the easiest way. That's my name and it's easy to find me. The sexualrehab.com takes them to the same place. And also ergorotics.com is where they can find the videos, where providers can also watch the video courses or also subscribe to the provider library of ergonomic sexual positions. For the convenience of clients, I curate products that help, that promote sexual comfort. Maybe dilators that may be helpful in the physical therapy world, or it might be hands-free devices for people who have a hard time holding devices, cushions that help modify positions. And some of those cushions are shown in the videos as well, how they might be used. I work with people anywhere. They don't need to find someone in their state if it's for sex counseling, because I'm an educator. So they're welcome to, ask me if I can help them with their concern. And if not, I'd be glad to help them find someone in their region or someone else who can help them.
Great. Yeah. This was amazing. I feel like I'm going to call you back for 6 other episodes.
I'm so glad we met though, Karen, and I'm glad you're doing this work.
Oh, thank you. Yeah. Thank you.